Friends, yeah. Good evening, friends. Welcome to Indian Arthroscopy Society Basic Knee Arthroscopy webinar today. We have past president of Indian Arthroscopy Society and a respected senior arthroscopy surgeon from Delhi, Gangaram Hospital, Dr. V B Bhasin. Dr. Bhasin is an eminent arthroscopy teacher and takes keen interest in teaching basic science of arthroscopy in almost all the category courses. His lectures have been a favorite hit. He's going to talk today about basic things regarding the instrumentation which you guys are going to use in arthroscopy, how to take care of your equipment, and to learn the basic trick of triangulation. He's got an innovative way to teach you and train you the basic tricks of triangulation. I think the learning instruments and learning the basic tricks of triangulation are two important things which all arthroscopy surgeons need. We also have Dr. Sameer Mehta from Delhi and Dr. Bhupesh Karthik, who is also a member of Indian Arthroscopy Society Executive Committee, joining in today as panelists. I would request Sameer and Bhupesh to intervene in between Sir's talk and coordinate so that this becomes interactive and informative. We also had sent request of to the members of Indian Arthroscopy Society, and we wanted at least 3 or 4 of them to join on the panel and ask questions directly to Dr. Bhasin in between his presentation and also after the presentation. This format of one-to-one interaction has been very favorite in the past couple of webinars, and we hope to carry on with this tradition in the basic arthroscopy series. Dr. Bhasin, welcome again, sir. And you can just start with small brief about what you want to speak, and then we can share the screen and take note.
Okay, so wonderful to interact with all the people. This is a very basic talk. People who are getting into arthroscopy, not the people who are all sitting here, but people who are wanting to get into arthroscopy, basic technique and technology, how to get the instrument, what should be a proper instrument, how to select it, and once you have selected it, how to take care of it, because these are all expensive, mostly imported instruments. So this is primarily meant for basic people who are starting up. I used to earlier call it how to set up arthroscopy. So this was meant for, and it will be relevant even today in tier 2 and tier 3 cities, people who are in a smaller hospital, smaller nursing homes, smaller setup, how to set up and how to take care of your equipment. In a bigger hospital, things have now changed. There are a lot of video arthroscopy and video laparoscopy, so people have become more familiar, more comfortable. But in smaller setups, peripheral setups, I think it is still important and be relevant for anybody starting new. So this is what I am going to speak today. So should I start my talk? Go ahead.
Yes, sure.
You know, okay. So I'll start. Should I share my screen now?
Yeah.
Okay, so arthroscopy setup and maintenance. This is what I call this talk. Arthroscopy is a wonderful technique to do surgery of the joint. People from previous generation and even in today's generation, when they see open surgery and when they see arthroscopy, there is a world of difference in visualization, in precision, in outcome, in rehab. Everything is much better with arthroscopic technique for joint surgery. It is a technique which is heavily dependent on the technology. In fact, it is only the technology of fiber optic, lights, illumination, video, precision, high strength, well-designed instruments. This technology makes the technique possible. So it is a technology dependent, technology developed technique. The technical part has some specialized skill which are general for all arthroscopy and some localized for specialized procedure. I will not be speaking of some specialized procedure, but the skill which needs for general skill of arthroscopy or for any video endoscopic, that will be my second part on developing hand-eye coordination. In the first part, I will be speaking on the technology which makes this technique possible. The technology is the technology of arthroscopy, instrument and equipment. It is purely because of these developments in videos, fiber optics, that this technique has become possible. So one must be very familiar with the arthroscopy instrumentation in order to optimally do this technique. So I'll be detailing on each small topics of what the instruments basic we use and what is the how we take care of them. The basic arthroscope comes with a sheath. The thing to look for and the feature to look for in an arthroscopy sheath is that it should allow a wide bore around the telescope. Usually telescope is a 4 mm wide angle telescope. It should have a good flow, so the sheath should be wide as possible. It should have dual rotating taps. Now these are the taps for inflow of tubing with saline. This can be used for suction. So when one is maneuvering the scopes, these tend to get entangled with each other. So if these taps can rotate independent of the sheath, which is a separate cylinder here. This is a separate rotating cylinder which is moving around this sheath. This permits the taps to be rotated independently in this cylinder. So if the tubing has got entangled, one can disentangle. Previously and even today, there are sheaths which don't allow this feature. So they may be available to you cheaper, but it is always good to have these sheaths which have got this cylinder to let these taps disentangle the tubing attached here. Another thing when getting a sheath is that it should have a simple locking mechanism. One has to hold this stick here on the sheath to put the scope in and then lock. It should not be a complex mechanism. So always try out the locking mechanism without having to look at the locking mechanism. You should be able to lock this scope or this sheath comfortably. So look for a simple operating locking mechanism to lock the sheath with the scope or with the trocar. Another thing, this sheath is introduced into the joint using a semi-blunt trocar. In 1990s and 1984, when I started doing arthroscopy, there used to be a sharp trocar and a blunt obturator. The sharp trocar was meant to perforate the capsule and the blunt obturator the synovium. But it always would go in as a sharp one and damage the joint. So now in present day time, it has been discontinued and one should take a semi-blunt trocar introduced into the sheath when one is entering the joint. 4 mm 30-degree wide angle scope is good enough for shoulder, knee, ankle and elbow. I have used it in all these joints and very rarely one may use it in the wrist. But believe me, ankle is best done, which a lot of people ask. Ankle and elbow is best done with a 4 mm 30-degree wide angle scope. It looks very attractive to get a thinner scope, but if you try doing these scopies with thinner scopes, then you realize that the field of view is severely limited. So you have a standard 4 mm 30-degree wide angle scope. A good feature to look in a scope is that the front lens, the lens which goes into the joint, should have a resistant coating, which is usually a diamond coating or something similar material to prevent the lens from getting worn out. A feature why arthroscopy shows the vision well is because of illumination of the joint. A joint is the size of the shape of a fist at the most. And if you illuminate it with 150 watt of light, which is sufficient to illuminate a room, you can understand that the joint is very well illuminated. Because of this, the arthroscopy provides good vision. In open surgery, to focus a light is a big issue. When open surgery is being done, here the light focusing is in your own hand. You don't have to ask your assistant to focus the light into the back of the joint or on the side of the joint, as happens with open surgery. So it is the illumination in the joint which makes this surgery more precise. So usually we have minimum 150 watts light. A cheap, inexpensive light source is a metal halide. This needs to have a white balancing for the camera to recognize the white part of the light. A xenon is a much better light source, and one should try to have a xenon. But if you have a cost limitation, then a minimum 150 watt light and a metal halide light with white balancing can be quite effectively utilized. Xenon is a much better, closer to the natural light, but it costs much more. A feature called automatic light source. What does this mean? That the light is sensed from the scope by the camera attached, video camera attached. And if the camera senses that the light is less, it gives a feedback to the light source to increase the light intensity. So if you are seeing in a distant space, the light intensity will be automatically increased by the input from the camera to the light source. It is a good feature to have, and most of the present day situation in bigger setups will have this. However, in smaller setups, you may not be able to have this, but it is a good idea. Especially relevant in smaller setups is the replacement cost of the bulb. You must find out what is the cost of the bulb at the time of purchasing your light source. You will be surprised for when the bulb needs to be replaced, what is the replacement cost told at that time. So be prepared and definitely buy or definitely be aware what is the replacement cost of bulb when deciding on the type of light source you need to take. A technological marvel which is one very importantly responsible for arthroscopy is the fiber optic cable. Normally the light travels in a straight line. So if one has to look inside the joint, one has to focus the line where one has to do directly over it. In fiber optic cable, one can bend the light and take it to the direction and the place one wants to do. So this is the technological marvel. Actually, it works on the principle of total internal reflection. Light still follows the principle of physics, but we have been able to harness this light into the direction using the fiber optic cable. Minimum 3 meters is preferable. Long fiber optic cable is needed, not less than 2 meters in any stances. The diameter of the fiber optic cable should be minimum 5 mm. It is important to understand that why should you have minimum 5 mm. Our scope has got light conducting fibers inside it. The scope is 4 mm diameter. So to have maximum optimization, it should have minimum 4 mm of light equivalent going through it. So a 4 mm cable should be sufficient, but why should we have 5 mm? Because with usage, some of the fibers in the cable will break, and if that happens, then at least 4 mm equivalent of light should still be able to go if you have a 5 mm cable. So this is what happens. So this is how we check for fiber cable, and especially important to check it periodically. And if you find that your joint is not well lighting, one of the factors could be this fiber optic cable. So one shines the one end of the fiber optic cable to any light in the room and then closely observes the other end of the fiber optic cable. If you see the slide on the right, there are some parts of the cable which have become black. So along the length of this cable, somewhere these fibers have broken and they are not transmitting the light. Hence, one will have some decreased light transmission. So even if some fibers are broken, if you have a thicker cable, it will still transmit the light needed for a 4 mm scope. So keep checking the cable and make sure that it is minimum 5 mm cable. This is what one should know. Video camera and monitor, one should have a system which can be put in a console which may be specialized, or in olden times we had this console which was locally fabricated to keep the shaver and the light source and the light cable. One must understand what is the what should be the minimum requirement in a smaller setup for these types of things. You know, the resolution of these systems is measured by the horizontal line resolution. It is best to find out what is the exact horizontal line resolution, not just the terminology of low resolution, high density or low density, but it is important to find out minimum 500 lines horizontal resolution is necessary for arthroscopy. For laparoscopy, where there is a vascular work, a higher resolution is necessary. But for arthroscopy, 500 lines horizontal resolution is the minimum sufficient one. The resolution of the entire system is limited to the lowest resolution within the system. For example, if you have got a camera with 600 line resolution, but your monitor is only 300 line, what you will see on the monitor will be only 300 lines. It is always better, if you have a consideration for cost, to buy a better camera, because changing the camera is a much more expensive proposition. Even if you have a lower quality monitor, you will be able to effectively change to a higher monitor at a much lower cost. So make sure that you have a compatible system of the TV and the monitor and the camera, and keep the resolution part in mind. Coming to the work tools, which is these were visualizing tools: scope, sheets, light cable, camera. These are visualizing, the vision part. Coming to the operative instrument: probe, knives, punches, grabbers, motorized power instrument, and specialized jigs, which are innumerable now with the advancements and the newer techniques being possible arthroscopically. So slowly we will share. Probe is the most basic instrument. Basically, it is a 2 mm hook in the front, 2 to 3, 4 mm you can use, depending on what space you have got in the joint. No arthroscopy can be done. All arthroscopy starts and ends with the probe. It is very important instrument. It is your palpating finger. You cannot put a finger in the joint. It is the palpating to see mobility of the tissue, to see the integrity of the tissue. What you would do in open surgery with your finger, this is your palpating finger in the joint. So it is one of the most important and the basic instrument. It has to have some certain basic structure. That means there should be a gradual thickness which is outside to a thinness which is gradually changing inside. It should be a stress distribution all along the length of the scope, or all along the length of the instrument. And this stress distribution applies to all the instruments. This is not a very specialized instrument, so even a local one will work fine. Knives. When arthroscopy started way back when we were getting trained in 83, 84, my thesis was in 84, knee surgery was being done with Martin's knife. They were knives which you could put on the meniscus and by pushing, cut the meniscus. That was the knives which were used. So when arthroscopy started, the same knives were modified, were put into the joint to do the surgery. But these knives are very sparingly used now, because they have sharp edges and they can very easily damage the articular cartilage. And since the depth perception is not as much as in a binocular vision, which is there in open surgery, one may over penetrate and damage the structures outside the joint. So by and large, knives have been discontinued. There is only one knife which I am using. It is called the hook knife. This has very limited use, which can still be used. Hook knife is good for lateral release. So one hooks this knife in the in the parapatellar retinaculum, right from the top of the knee where there is vastus lateralis, and by pulling on this hook knife, one can make a long cut in the retinaculum quickly. This can quickly cut a large tissue in suprapatellar pouch. One does not use this knife anywhere except in suprapatellar pouch. It is also useful for, apart from a quick lateral release, which can be very well done with this knife, also useful for removing the scar tissue from the joints. Okay, so one can hook around the scar tissue in the suprapatellar pouch, and by pulling on the knife, one divides the scar tissue quite rapidly. It is not to be used in the tibiofemoral area at all. Hook knives were available and are probably still available as a single piece or as a replaceable tip. That means when the tip gets blunt, you put in a new tip. It looks very attractive, but I would strongly advise you not to go for this replacement tip, because the tips can break inside at the point of attachment, because there is a junction between plastic and metal. The two have different elasticity and there can be a stress at that area. So never buy the replaceable tip hook knife, as it can break. So go for a single piece hook knife. Another workhorse is the grabber, which is useful for cut tissue to be removed from the joint. Meniscal grabber, loose body grabber. See, like this is a meniscal grabber. It has straight, it has serrations here. A loose body grabber will be a little cupped so that it can grab the body, loose body better. A pituitary grabber is a compromise and equally effective for a combination of meniscal and loose body grabber. It has some cupping, it has some holding power. So pituitary grabber is a good thing to have in case you need a grabber. Grabber with ratchet locking mechanisms are also there, but they are not very comfortable to work inside the joint. One may have it, but simple pituitary grabber, even if it is a locally available one, works fine, because this is not a high precision instrument. One can go for a simple pituitary grabber. Punches. This is the most important and the most delicate instrument. One must have them of the best possible quality. A 1.5 millimeter, which is the width of the punch, 15-degree up punch, which means angled 15-degree up right in the front, is the workhorse. It was initially made for doing meniscectomy in the posterior horn. This area could go on the posterior curved part of the femur and work from under the meniscus to do a meniscectomy. But it has been used now for every procedure. This same 15-degree up punch can conveniently be used by rotating in different directions. So this is the main workhorse. How to select a proper punch, I will be sharing in the next few slides. Another punch which is useful is a 90-degree rotary punch. So if you introduce this straight punch, I'm talking about the straight punch, and one has to cut in front of it, and one goes from anterior portal for medial meniscus, then one can go right till the posterior horn, because the horn is in front of the knife. But as soon as you introduced, you cannot turn back and cut it the anterior horn. So for this purpose and for anterior horn of the lateral meniscus, it is important to have a knife which is a rotary 90-degree. So the cutting edge is at right angle to the direction of introduction. So if one does not cut in the front, but cuts at right angle. So this is useful for lateral meniscus, also useful for anterior horn of medial meniscus. Do not compromise on the quality of knife. Scissors, they were available and I'm sure they are still being sold. Never to be used. They are delicate. They will break inside the joint. So always use punches and not scissors. One must avoid instruments which have got hinge pin inside the joint, have got projecting parts, ill-fitting cutting edges, or there is a sudden change in direction or diameter of the instrument. This makes the instrument prone to break because of stress concentration at the point of bending, or where there is a change of diameter or the dimensions of the instrument. So I'll just share with you the examples for each of these. Cutting edges are the most important. You can see the one on the right has got the cutting edges which are very well fitting when the instrument is closed. So this will sharply cut the tissue and not grab the tissue. Whereas the one on the left, also from a reputed imported company, very much being sold. If you see the difference, the cutting edges are not well fitting. And the best way to see this cutting edges fitting is under the magnification of the video. But this is visible even to naked eye that the cutting edges, there is a gap. So the tissue will get caught, not cut. And one will put more force to cut this tissue, then the instrument is likely to break. So it is important to avoid this type of instrument which have got ill-fitting cutting edges, which will not be cutting, but it will be shearing the tissue. So important thing is to see the cutting edge. Another important thing is that the one on the left is not a good instrument, because when you open the instrument, there is a hinge pin inside and then there is a projecting part. Now this part, when you move the instrument, will scuff the cartilage. The one on the right is a good instrument. It does not have a hinge pin. It has a sliding mechanism, which is very much there in the flaps of an aircraft, that the movement occurs along a sliding mechanism inside this area. Let me tell you if I can point it out. There is a sliding mechanism inside. The instrument is so designed that there is no projecting part here. So this is a good mechanism. It does not have a pin inside, and at the same time, there is no projecting part in this instrument. So one on the right is the right thing to select. Another thing is important. The one on the left is an instrument from a reputed company. It has a circular front part and a rectangular back part in the handle. This instrument was designed that there should be stress here rather than stress inside. And believe me, this instrument used to very frequently break at this area. So it is not to be purchased. It is important to have an instrument which has got a gradual change. It should be thick here and gradually thin down. I'll go back to the previous slide. If you see, the one on the right is a good instrument. It is thinning down gradually from back all the way to the front end, and there is a smooth transition, never a sharp transition. Another thing one must look is sudden change in direction. The one on the left is not a good instrument. There is a sudden change in the direction here. So this can have stress concentration at this point, as well as scuffing at this area. The one on the right has a gradual smooth transition. So the stress is distributed all along the length of the instrument rather than being concentrated at a particular edge of the instrument. So the one on the right type is the right type of instrument to have, and one must look for it when purchasing or using these instruments. Coming to the next set of instrument is the motorized power. This is useful for rapid removal of large volume of tissue from the joint, and it is useful in stiff knee, synovectomy, debridement, and all those procedures. Most of the time, these instruments are now a standard. When I started doing arthroscopy way back in 1990, these were a big luxury at that time. But obviously, anybody into it should be having it. You must understand there are two types of power. Sometimes in our country also we have had two types of power. So we have to understand the interaction between the two powers. There is a suction power and then there is a motor power. The motor rotates. There is a cylinder which is stable outside. The inner cylinder rotates and cuts the tissue when it is inside the mouth of the tissue. The sucking of the tissue inside the mouth is done by the suction power. So if you don't have a good suction, the tissue will not get sucked in for the motor to cut. Another thing important to understand is that if your motor is rotating at a very high speed, then this area will not be open for a sufficient time for the tissue to get sucked in by the suction. So if you operate it at a very high speed, the motor will keep on rotating, but the tissue will not have the time to get sucked in. So keep the suction high if you are cutting soft tissue, but motor at a speed of 800 to 1200 RPM. That way the tissue gets sucked because these things remain open. The mouth of the shaver remains open for a little longer time. Present day time, we are using mostly oscillation mode. It moves in one direction, then there is a small gap and moves in the opposite direction. That is probably the best way for synovectomy and soft tissue removal. Then why have a high speed? High speed is needed for drilling in the bone. High speed is needed for shaver, where one has to work on a hard surface. Anything which is rotating on a high speed is stable, like called the gyroscopic principle. Like you have a bicycle, it is very difficult to keep it stable on a ground which is hard at a slow speed. If the ground is soft, it may still be stable, but it is very difficult to keep it stable on a hard surface. So if you are moving the bike, it becomes stable. So one must have a high speed if one is working with a burr on a bony tissue, on a hard surface. So that is the reason one must have a high speed also. But most of the time, for removal of the tissue and cutting, a good suction with 800 RPM to 1200 RPM for the motor is a good enough. It comes with the various tips which are disposable. Presently, you are having reusable tips which are quite effective, and they are available for different models. In old time, there only used to be disposable, but we used to reuse all of them because it was not cost effective. One can use burrs which are also available in different shapes, rounded burr or a recromizer burr. One should have 1 or 2 burrs available, but most of the work is done by your a shaver, which is a synovectomy type of a shaver. A different diameter for depending on the volume of the tissue to be removed and the space in which you are working. So if one is working in a suprapatellar space, one may use a thicker 4.5 or 5 mm diameter shaver. But if working in tibiofemoral joint, one may have to use a 3.5 millimeter diameter shaver, since the space is a constraint. I must stress that one must have minimal instruments needed in this procedure. 3 instruments, one can do 90% of the commonly done basic procedure, which is probe, grabber, and punch. And one must make sure that one have these of which is comfortable with. Another important factor, since this is a specialized procedure, now very commonly done by other specialties, but when it started, it was basically arthroscopy which started using the videos. Now everybody is using it. So these factors have become less relevant, but still all the more relevant in smaller setup. Use the same operating room and the staff so that your staff is familiar with how to connect the light cable, how to connect the camera, how to connect the, and if there is any flaw in the system, they should be able to understand. So use the same operating room staff. Otherwise, you will be struggling with the connections which are done by people other than you. Keep a lateral thigh post for valgus stress on the knee. That is sufficient. One does not have to use a knee holder. One has to have a good waterproof draping. If you have water dripping all over, firstly, it will be uncomfortable. Second, it will be unsterile once the water has leaked out. One must put camera in a sterile waterproof cover. Cameras are all soakable, but it is still better to put the camera in a sterile cover in our type of setup, because if there is a leakage in the camera system, which can occur, I'm not saying they are very well made, but if there is a leakage, then once your camera is gone, you will be handicapped, especially in smaller towns. There may not be a replacement available, and replacement will come at a cost. So best is to protect your own camera, put a sterile waterproof cover. How you do it, I'm going to share it. Use minimal instrument. The lesser the instruments you have on the table, lesser is the temptation for you to keep changing from one instrument to another, thinking that the next one will be better. You will become more proficient at using the same instrument if you have lesser number of instruments. Your trauma of coming into and coming out of the joint will be less if your options of instruments are limited. But believe me, you will become more proficient, and you will understand that companies which are trying to sell more and more instruments, so many of them are superfluous and they are not needed very much. You can do the same thing once you are proficient with one instrument. So you will become proficient if you have lesser number of instruments. Another important thing needed, especially for a beginner, is to have good patience. This is how you do cleaning and draping. We normally clean with alcohol, then scrub it, then put it with betadine. Betadine, once it is put, then we do waterproof draping. This is the standard thigh post. We cover it with a sterile, this thing. This is how we cut a steri drape, 3 smaller pieces and 3 bigger pieces. How and where we use? We take the smaller piece. Okay, so this got redone. No, we'll have to go back a little bit. Yeah. So this is how we do. We have to read. And once this betadine is painted, it takes 10 minutes to work. Iodine takes 1 minute, betadine takes 10 minutes to work. And then we take this 3 sari drape, we cut it. These small pieces are used for draping of the scope. So one just see, one puts this small sari drape, and now observe closely. We twist the sari drape. So one sticks it to the scope head, the scope where the camera is going to come, then turns and twists it. Just observe it now. So you put it and then turn it around. So one has stuck to it. Now the sticky surface of this sari drape is to the outside. This is important for you to learn it. So now the sticky surface is to the outside, and if you lift it, it sticks. Can you see that? So we put this sticky surface inside the camera cover. So this seals it from within. This makes sure that it is tightly sealed. Then one twists the camera cover, and one has to firmly seal this end. So one puts that plastic covered metal wire. So this tightly we keep it winding it so that it tightly holds the camera cover. And then we railroad this camera and put this sheath, put the camera cover over the scope, so that the eyepiece is delivered here. This eyepiece is given to the attendant to attach an unsterile camera. He pulls the camera cover over it. Now this is where we utilize the other small cut sari drapes. We can't put towel clips because that will destroy the sealing. That will make holes. So this is how we utilize the rest of the sari drape, sticky sari drape. We use it instead of the towel clip to secure the camera and the light cable at one particular place. And this is how we seal the ends of the waterproof draping, by attaching the remaining bigger sheaths, bigger parts of the sari drape, one at the thigh, other at the leg. This is important to keep it waterproof for sterility reasons. Okay, so one has to make sure that one has done this and utilized it. Okay, so this is how one does this. I think it has started playing again. We have to move to the next slide. Okay, so some of this is not important, but you know, if you have a setup where the flooring is little delicate, one needs to suck the fluid. So this is a, let me have to start again. 1 minute. Okay, so this is the how we do a mopping system for the water to be sucked. So this is a white tubing which has previously been used. It is unsterile. It is not the sterile. It has been used in the previous surgery. So what we are doing is making small holes, putting it on the floor, and attaching the OT suction to it. And on this we put a sheath. Now this sheath will suck the water, and it will keep your flooring dry. This idea came from observing my neurosurgeon colleagues in the adjoining theater. In the brain surgery, they put a cotton pledget and put a suction on top of it. That sucks the fluid. So by the same capillary action, that piece of cloth will suck the fluid, and it will be removed by that suction using that white tubing. You may use it if your flooring is delicate, which can also occur. Okay, so once you have got all the instrument, you're starting up, you have to know what should be the care of instrument. Now we are all familiar, we can autoclave most of our orthopedic instruments, but these instruments, they are specialized in, sometimes the scopes are not autoclavable. If the scope is autoclavable, even there the temperature and the duration you must know, and not only you should know, the person operating the sterilizing setup should know that at what temperature can they use autoclave this scope. So they are delicate. If one not does that recommendation, one can damage the scope, etc. The cutting instruments are very sharp. So if you keep autoclaving them repeatedly, you are likely to get blunting of those edges. So that is the reason this requires special care and how to take care of it. So at the end of the procedure, you must wash. It is not that it has been saline. What is there at the end of the procedure on your instruments and scope?
Sir, share it again, sir. I think it got unshared automatically.
Okay.
Yes, sir. No problem. Meanwhile, anyone has any questions can ask the sir till sir start sharing again.
How do I share? Okay. Let me see.
Sir, the green screen, sir. The green button.
Yeah,
Green
pressing it.
on, yeah.
It's not pressing.
Sir, keep the presentation. Yeah.
Now
Yes,
it's
sir.
Yeah, Tirath, you can ask the question.
Yeah. Good evening, sir.
Good
Actually,
evening.
I wanted to ask, like most of the time we are struggling with the budget issue. So this motorized instrument and the RF, if at all, can we reuse them? And if at all we can reuse them, then how many number of times we can do that?
Okay, very relevant question. You know, Dheeraj, what we want is that the power shaver now has got reusable blades available. Earlier, I would say that one shaver blade I could use in 10 cases. Okay, so one would wash it, one would dry it very well, put it for sterilization by ethylene oxide, and one could comfortably use it for 10 usage. They do start breaking. How to detect the breakage, I will be speaking in the subsequent part, but definitely one has to reuse them, otherwise it is not cost effective. Problem with RF is that these people are smart. They have built in that this is the number of hours that it can be used. So that is purely with the intent of not letting you use it. Now you have to be smart to understand that what is the aim. Aim is not just to provide a better RF. Aim is to, provide better commerce. So RF people have got out of it by doing this thing. Okay. So that is the difficulty. So use it selectively. Believe me, you may use it. Once you start using it, you get addicted to it. But better to use it selectively.
There are commercially available reusable shaver blades which are there. They are metallic shaver blades.
Yes, they are right. They are very good. So in fact, now we are not doing the same thing. We are not using it. We are using the commercially available reusable shaver blades. One company makes it for all models of the shavers. You just have to tell them the model. They are available from Bombay.
Okay.
Sir, I think the radio frequency that we use, it was initially meant for shoulder, isn't it? And is it a luxury to use in the knee?
Don't use it.
It's a
That's what
luxury
I said.
actually, and we don't really need it.
falling
Shaver
into
does
the
most of the
trap.
work.
That's what I'm saying, that you are falling into the trap. In shoulder also, when there is good hemostasis needed, I think that is the time to use it. It is good for shoulder because knee, although we are doing knee without tourniquet now, shoulder does not have a tourniquet, so one may find radio frequency better. But believe me, for knee, don't get into it. Don't get into it.
Dr. IPS, sir, how often do you use radio frequency and when, if ever you use in the knee?
So I don't use it very frequently. Sometimes you see cutting the part of meniscus in the back is a bit difficult. So you can use a hook cautery device to just cut it easily. So it is a single go. You can just cut it and then remove the piece, because sometimes nibbling it is a difficult thing. And very, very rarely we would use it on the radio frequency on the articular surface where there is crab-like appearance of the articular cartilage with a lot of chondral fibrillation. So you can use a gentle shaver or maybe a gentle radio frequency. But definitely indications are very, very less as compared to the shoulder. So we keep it as a standby, but maybe out of 100 cases, just 5 cases, 4 cases we use.
Yeah.
Correct. Correct. Thank you.
I think Bhasin sir is ready with the continuation.
Yeah.
Of the
So I was just coming to it. Once you have done your procedure, you must wash the saline. Saline causes rusting. So you have to use water to wash your instrument, clean it up with soap or commercially available material. It dissolves the proteinaceous and the fat deposit on your instrument. It is important to remove all organic matter before you give this instrument for sterilization by ethylene oxide, Sidex, formalin, anywhere which is being utilized in your thing. And one must give it a good water jet to mechanically remove any of the tissue. One can use commercially available dissolving agents which remove the proteinaceous deposit. Then one can use the air power in your operation theater to attach an air hose which is used for pneumatic to dry the instrument. It is important to dry all the joints, especially if you are not going to use it the next day. And if you let it remain, and it can rust and cause the instruments to the tap to seal up. One must store them in a proper place. You know, we have seen large boxes of formalin available. If you have a large box, the instruments keeps moving from one side to another. So it is always better to have small boxes. Nowadays, companies have come up. This is 15 years ago, an airtight box which will not allow the instrument to move and keep it at a place is what we used. This is one of the methods. We used to cover the cutting edge with a rubber cap so that it is not colliding and keep it in this airtight box. There are other types of airtight boxes also available which we can utilize. And it is important to keep them. And we used to keep them. So this is the same different mechanisms of air suction to remove and dry the instruments. So these are the various boxes. What I was referring to was this big box which I used to use in 1990. It is the one commercially available, but this used to break. The instruments used to move from one side to another. So we came to smaller bread boxes, especially for storage. Then we came to these smaller boxes with cutout. These cutouts allowed the cutting edges not to collide with each other. They were locally made from the airtight boxes which you get mostly at Diwali time and things like this. So these all have been devised, but now they are all available from companies, and they have all come out with smaller sized fitting boxes. But some places, if they are not available, one can use boxes like this which allow the instrument not to collide and also keep the cutting edge protected. If you can see, there is a rubber cap on the cutting edge of it. And this is important, especially for if you are not going to use every day. In older time, the two methods were formalin tablet, which are hardly ever being utilized now, but it is a very not the most effective method. It cannot destroy spores. It is not the best method now. Way back in 1990, when I started this procedure, this was the method being done at that time. Sidex had come in that time. Nowadays, Sidex is a good method. One must understand two things. The Sidex has a yellow color. There is an OPA one which has come, which does not have that color. But if you are using the conventional Sidex, it has yellow cover. So it has a yellow color. It may get coated on your scope length if you let it remain and keep on using it again. So this is a little disadvantage. Another disadvantage of Sidex is that there should be no organic matter. If there is organic matter present, whether for Sidex or for ethylene oxide, that method will not work. So it is important to do the first part, which is use air jet and water jet and chemical surface cleaning by commercially available or by soap and water to clean the surface of any organic matter. So Sidex is a reasonably good method, inexpensive, available in smaller setups. It has an advantage also. Formalin, you cannot kill spores, but normal Sidex requires 20 minutes of soaking. But if you have done an infected case, you need to keep the instrument soaked in Sidex for 6 hours if it is infected due to septic knee or hepatitis case. So it is important to still we use this Sidex after having done a scopy for an infection. We still Sidex soak it and then give it for ethylene oxide for the same purpose.
Sir, Dr. Nishit has a question. Nishit bhai, you can ask questions, sir. Dr. Nishit, unmute yourself, please.
Nishit sir, you should unmute yourself, sir.
Unmute, sir. Yes, sir.
Am I audible now?
Yeah, you are audible, sir.
Yeah. Bhasin, superb things. One thing that I could not understand, one thing was that your suction device from the floor with the old layer. And second thing I wanted to ask you that, as you rightly said, that nowadays the formalin we should not promote because it also.
Yeah.
And third thing, what I wanted was that if you have to, you have said 3 instruments, right? So only one basket punch to be.
Yes, I only have for the last 30 years, my same basket punches are being utilized.
No, but how many? How many? Because as I understand, you said you need one basket punch, one probe, and one. That is what.
For the common surgical, obviously, if you need specialized jigs, you need other instrument. That is different. Curate.
I am talking about only basket punches. Which?
Yes, only 1.5 millimeter, 15-degree up basket punch is sufficient for most of the procedures. Rotary punch for what I said, anterior horns or lateral meniscus. Believe me, this is all the basic instrument. When I started, in even today, I don't have wider or more angled, right angled, swept, up swept, left swept. I don't think one has to use them.
Right. Okay. No, I was thinking that because the Indian joints sometimes, especially in these ladies, they are very tight.
Yeah.
So if you are not very good with making the multiple holes on the middle side, what we call, then the joints are tight. So I think that even 1 millimeter or 1.1 millimeter upbiter sometimes really makes useful.
Yeah, okay. So that's a good experience you are sharing. I have not used it. I have been using 1.5, which is, I find it all right. But if 1.1 is available, I am sure in the situation where you are telling people who are short have tighter joints.
Yeah.
People who are short. So which is
just my thoughts.
Yeah. So that I can accept. I would say yes. So you were asking about, one of your question was, that is a mechanism to remove the water from the floor, because some of the floors are very delicate with the present coating. They tend to soak up and swell up. So you don't want. Yeah. So you have got commercially available now. I'm saying now you are available. There are, basically things which you attach your suction. They are available. So one could have used it. What is this is, we have taken a Y tubing, which is our old used Y tubing, closed both the ends of the Y. The one end of the Y we attach to the suction. The other end, so that it sucks fluid, we make multiple holes into that tubing.
Right.
And we put this tubing, and on the top of the tubing, we put an ordinary operation theatre cloth where the water is falling. This idea came to me. My adjoining theatre was a neurosurgeon. And what they would do is they will put a cotton pledget on an open brain, suck with a suction on the cotton pledget. So cotton pledget by capillary action would collect and the suction. So they used it very effectively. So what we are doing is that the capillary action is by the cloth put on it. It sucks, it absorbs the water, and the suction sucks out and removes it. You could see there was a lot of water getting collected.
But the thing is that, as I understand, that all the shower system to function properly has to have a minimum pressure.
Yeah. Oh, this you are talking. Okay, I thought the floor system.
No, I understand. But when you're saying that you are doing a Y connection between
this is when the water is falling. It may fall because of your leaking from the portal. Yeah.
No. Water will fall always. I understand. So as I understand that you are making a Y connection, one connection goes to your suction, your shower system. The other.
No. The suction.
But suction, you have a Y connection at the suction. One goes on the shower and one goes on the floor, right?
No. So Y has two mouths on one side and one mouth on the other side. So these two mouths are sucking water. This is the end which is the separate end goes to the suction. So the two limbs of the Y are sucking the water from the floor.
It has no connection with your shaver system.
No, nothing to do with the shaver. This is unsterile. This is on the floor. This is not that important. You have other alternatives available.
Okay, I understand. There was a mistake in my.
Yeah, that's the good you clarify. Other people might have had the same confusion. I might have not been that clear on this. I might not have been that clear on this.
Yeah. Let's continue.
Okay, so basically arthroscopy instruments for the purpose of sterilization can be, instruments which have got delicate optics like your scope, which has got lenses, so you can't autoclave them at the usual temperature, and not at all kept with other heavy instruments like hammer or drills. They will certainly damage the optic. So one has to understand delicate optics. Metal with sharp cutting edges like punches, autoclaving them has a price to pay that the edges will get worn out. Metal with no sharp edges like grabbers, probes, hammers, they can be autoclaved. Supposedly disposable in the West, which the weaver calls like reusable cannula, we are reusing them. So we are what I call as supposedly disposable in the West, we are reusing them. We are not disposing them. These are plastic cannulas and shaver tips. Believe me, wherever there is a ethylene oxide being utilized, that is the method for most of these instruments. They are sufficient. But for a smaller setup, in a smaller area or a newer setup, one must understand that arthroscope or fiber optic cable, best to put it in Sidex or use a formalin vapor, minimum 6 hours in a saturated chamber. If you have a low turnover setup where you are doing one scope maybe after 2 or 3 days, then this method where the instruments remains in the Sidex, in the formalin vapor chamber is a very good method. It has some limitation. One must be sure that one has not done an infected case and not the best method, but in a smaller setup, it is inexpensive, it is universally available, it is portable, it causes no harm to the optics, and it causes no corrosion as can occur with a long Sidex utilization.
Can I ask something?
Sure.
Bhasin, how much time one should keep the instruments outside if I use the formalin chamber?
You can immediately take it out. It is white. You can use it. You don't have to air it.
Does it not collect some poisonous?
Oh, you wash it. You wash it before you use it.
I understand, but so yeah, there is no need.
No, it does not have a residual effect on the metal.
Okay, and you wash it with what? Usually saline.
Once you have it, a sterile saline. It is the same saline through the white tube. You wash it. Nowadays, believe me, we are not using it at least in our setup, but it is useful for a smaller setup. Yes.
Yeah, absolutely. No, but see, the problem is as you said, that it's nice to have a good formalin chamber, which the instrument doesn't, because if they collide with each other, they lose a lot of potency as well.
So if you have a smaller chamber, the concentration of formalin vapor will be high.
Yeah.
So use a smaller chamber.
Yeah.
Sir, Bhasin sir, just to add to what you said, of course, as you said, formalin should never be used. But over the period, what we have noticed is two particular instruments where formalin should never be used is the camera and the shaver. Because with camera, formalin deposits start happening just behind the lens and the quality of the camera goes away very early. So now that we have sterile covers that you showed us,
So we have used the sterile cover always. So I never tell the camera. I said even in the beginning about the camera that we don't even Sidex soak the camera. Even the same thing happens with the Sidex soak. Right. Apart from danger of leaking, the shaver we have utilized for about 10-15 years. Now we are not using formalin at all. But I did not find the problem with the shaver. But I am not aware of it.
Many times the suction handle, the small button, it gets stuck if we put it in the formalin chamber.
I'll tell you why that happens. Yeah. I'll tell you that happens, and I have treated it also. It happens because the saline remained in that small joint and it got rusted. So the rust I have removed with the anti-rust available with car mechanics. They use this spray. It is very cheap, easily available. Just spray it. Even if it is your scope tap which gets, that is because of rusting. I don't know if it is because of formalin, but I have had that experience.
Because of formalin, the inner coating of rubber in the shaver handle, the rubber becomes hardened. So the quality of the shaver motor starts giving a weird noise. And again, the life of the shaver goes off.
Bhupesh,
Okay,
you need
okay,
to
okay. Maybe yes. Yeah, but it can. But it is being. I'm not using it at the moment. But
Correct, sir.
somewhere there is a limitation. This is one should be aware of this method. That's all.
I think Bhasin, these instruments are high steel instruments. They will not rust. I think the deposit of the blood and the matter which is not cleaned properly, as
Yes.
your proteolytic enzymes we have to use. If
Yeah.
you do not use it, then over the time that blood and everything looks like a rust. And
Yeah.
many times you said that if you soak it, and that is why I think, I don't know whether you're going to speak or not, but I think the ultrasound cleaning
Is good.
makes
Yeah.
it. Yeah.
Okay. You know, you have seen Dr. Whitwitty. We have worked with Whitwitty way back in 1988.
Yeah.
He was only using in Germany formalin chamber because he used to do 6 scopies. He used to have 21 scopes ready. So each one was used on the 3rd day because it basically takes time. So this is what was the utility at that time. In present day time, the times have changed and we are probably relying more on ethylene oxide, I think.
Right.
That's what we are doing, more or less. But still, for a smaller setup, they should be aware that this is the method for using for the scopes. So ethylene oxide is a better method any day. Sidex 20 minutes, or for an infected case 6 hours. You can do many cases in a one day with low inventory. The disadvantage is it coats the lens yellow and can cause corrosion because of the liquid.
Sir,
Okay.
2 questions. Can I ask 2 questions?
Yeah.
Okay, so question 1 is, so the shaver blades that we use, we can use a number of times. You just said a while back. Sir, is it a provision? I know that abroad, maybe in US and other countries, the company takes these back and repackages it, kind of recycles it. The company does it. So have you explored this in India? I mean, the same companies are here, like Smith & Nephew and Arthrex and so on. So can we give the shaver blades for reusable to reuse them again later on?
No, I don't understand. There are reusable blades available from some company. That is what we are using now.
Bhasin, may I see there's a metal shaver blades, right?
Yeah, those are metal.
So the problem is that what I found was that the fitting with the existing shaver handle is not so good, you know. So over the period of time, the life of the shaver handle goes down when you use this metallic reusable shaver blade. I do not know what is your experience. I would like to know from you that which company you are using, because I am using a Smith & Nephew handle. If you are using the same handle, I would like to know that which company you are using.
Okay, the handle can be any company, but the company which makes it for that specific company. Yeah. I think it is working well now. I have got about almost 10 years that I have used it. To the question, sorry.
Use it?
You know, when I start feeling, it depends on the usage. If I start feeling it is not cutting, it is just grabbing the tissue, we keep a spare one available, so we change, but it lasts a good amount of time. I think it is worth the value. That's the reason we have shifted. As far as Sameer's question of repackaging ones, you know, the ones which you have used yourself, why don't you dry it, clean it, dry it well, and then re-sterilize by ethylene oxide, which is being done for your cannulas also, or you can Sidex soak them also. So why give it to the company to do it? I mean, you can do it yourself, Sameer, I think.
Yeah.
Okay.
Sir, this is a good idea. And my second question was, sir, the dryer, I saw you were drying all the instruments, and that's a very wonderful thing, but most of us don't have these dryers.
No, the pneumatic, these are pneumatic, जो drill जिससे चलती है, जिससे drill चलती है.
Connect to the pendant.
Okay. Yeah.
Okay.
It is the air drill. It is the same one, which is the air drill. There are some which have got low pressure dryer attachment.
Yeah.
So I use the same nozzle which
that gun is available for 500 rupees to 1,000 rupees.
Yeah. Now it is available. Earlier we used to use only the pipe.
Sameer, you can buy a commercially available the air pump, which this cycle wala uses. And you can have a filter in between, and then Stores makes very nice gun. Okay, so if you have money, if you have
Okay.
you
So
buy
you
this.
use the outlet. What I did initially was, when it was not available, we used to just put it in the, at that time in 1990, it used to be air cylinder, not these wall attachments. So we
Yeah.
used to put the same nozzle into the air cylinder. Other end of the pipe was kept open. So high pressure would just drive the air away.
Yeah,
So
absolutely.
yeah, that's what you can do.
Okay, that's wonderful. All right.
Okay. So should I go ahead? So
Yeah.
coming again to metal with sharp edges like punches, they are expensive, they are delicate. People can use them in autoclave, but then their life gets decreased because the cutting edge gets blunted. So good compromise is a ethylene oxide or formalin or Sidex. So between Sidex and ethylene oxide, whatever one is available with, one can use it, and they need to be protected. Especially when storing them, make sure that their edge is well protected, because this is the most expensive instrument for most of your works. Reconstruction jigs, they all can be drills, probes, implants. They are best done through steam autoclave as they don't get damaged. Now, supposedly disposable in the West, there is a very small point one has to use, like cannulas, shaver tips, burrs, they have got basic plastic and metal. Formalin vapor can be utilized with proper drying. Ethylene oxide can be used. One can use Sidex also. The point to remember is that if you put a Sidex cannula in a Sidex, it will float up. So it will not be effective because basically it works on the surface. So put a Steinmann pin in a cannula which is plastic. It will make it sink. It will remain soaked. So this is the only thing you need to know. Put a Steinmann pin in a cannula so that it gets sunk into the bottom of the Sidex and it gets coated all along. That is the only thing. Otherwise, ethylene oxide is probably a standard. But Sidex, one should be aware that they can float up on top. Make sure that once your OT assistant has put them in Sidex, they are well soaked. Okay.
Very nice, boss.
Yeah, thank you. Another thing which is not much relevant now is one should take care of the equipment. One must have a constant power voltage. Nowadays, not a problem in bigger cities, but all those of you who have worked in 1990s, 1998s, they know that the power fluctuations were phenomenal. They can damage your camera. So I used to use my camera at that time on a battery so that there is no power fluctuation. You have got now UPS, CVTs, all those things. One must have spare bulbs and fuses. One must do periodic check of the light cable and the fine instrument. How you do it? Light cable, I told you, shine one end of the light cable to any light in the room. Look at the other end of the light cable. If there is more than 30% of it appears black, that means these many fibers have been broken. Then you need to change the light cable. Okay. And how to prevent this breakage of the light fiber is, don't keep it tightly packed in a small loop. Don't make a small circle. Minimum 9 inches of space should be available for the light cable so that the fibers don't bend and break. Okay, so these 2 points are important. The looking at the breakage and giving it adequate space when you are storing it. How do you check? All these scopes have got light conducting into them to take the light inside the joint. So this light goes from here at the the scope and where the camera is there. So, but how do we find out what is the light conducting? In a dark room, shine the light from the light cable at the joint end of the scope and see what is the illumination where you attach the light cable. As you can see the slide on the right, this has been done in a dark. The top scope is conducting much more light. The fibers are not broken. In the lower scope, probably some fibers are broken, so it is not showing good illumination where you attach the light cable. This is how you check, especially if you are buying old reconditioned scope. Make sure that you do this maneuver. Instrument fatigue and cracks are best detected under the magnification of the video camera. So when we have been reusing our disposable shavers, and that is when you detect the crack. This crack was not visible. So the best way to detect is, now this is inside the joint. One doesn't have to do it inside the joint. Ideally, it should be done periodically under the magnification of the video camera. Look for any cracks or gaps or scratches which can be best seen outside the joint. Okay, so one must remember that cost viability when you are setting up your own setup is important for ethical reasons. If you buy unnecessary instruments, you will have unnecessary reasons to do procedures. Probably a very important factor in present day time is that you should be very clear in what you are doing and you should be able to justify the cost. So this was as far as the instrumentation talk was concerned.
Sir, there are some questions coming up, so we can have some questions. And
Yeah,
if it's comfortable to you, we can have triangulation talk maybe after 2 weeks or so, sir.
I can do that. I am okay with it.
Yeah, because here we have a lot of questions coming up, and I think we will.
Yeah, I am also happy. I am okay. We can do that.
Perfect, perfect.
Basin,
Yeah, so
can
let's start with Dr. Nishit, sir. You were asking something.
IPS,
Yes, sir.
Basin, I think you have forgotten about the oiling part.
Okay.
Yes. Yes.
Oiling is very,
Oiling
very
is important, sir. You need to tell how oiling is important.
Yes, yes, yes. You know, it is so infrequently done. There is a silicone oil available for the taps. But believe me, if you are using it regularly, I don't think I have ever gone into it. My OT technician could be putting silicone oil, but that's very rare. So if you are using it, then unlikely you will need oil. But if you are storing an instrument, make sure it is dried. You may put one drop of silicone oil at the taps of the sheath joints. Yeah.
and also when you want to oil the shaver system, the spray and the drill, the spray is available. The silicone spray is available where you have to put it on the where you connect the cable of the drill. And there you have to put this spray and you have to run the drill so that your drill, you will be able to oil the drill properly.
You know, that is not the oil. That spray is an anti-rust I was telling you, which all the car mechanics use.
Sir, it is
No, there are two
WD-40.
things available. One is
It's called as
anti-rust.
WD-40.
Yeah,
Okay.
no, that is
that is available. You're right.
anti-rust.
WD-4 is available at all car mechanics.
no.
Right, WD-4. You are right, Biraris. Sandeep, you are right. That is the one I use. If there is a rusting or anybody else's scope, urologist, so many of my colleagues, there when the scope gets stuck, they ask me, and that is what I do.
No, sir. Dr. Nishit Shah is saying that the silicone oil, usually these AO or that synthesis people, they recommend to be put for the drill where there are the motorized parts.
Yeah.
For maintenance.
So that I think the oiling makes a lot of sense for the and I think third thing is that everybody should understand that these are the very delicate instruments and you have to have a backup of it. And second thing that you will have to invest into the money again and again for certain instruments. Okay.
Correct.
Bhasin sir, fantastic talk, sir. It was very informative.
Thank you.
One doubt I have is about the light source. Now,
About the
light source.
Light source.
Now, most of us have the confusion of having two generations of light source. One is the xenon cold source. The other is the LED light source. What are the differences? LED seems to be a little costly, but the working hours is almost 10 times that of xenon. In your experience, is there any difference in visualization? Is it
no, what previous generation was metal halide. That you are not talking about the metal halide.
No. Between xenon and LED light source.
LED will be better any day. Okay. Because you know you waste less energy of light in LED. The amount of energy of light, there is no heat generation. So that is better any day.
Can I answer this?
Yeah, please, sir. Please.
See, 5600 Kelvin is a daylight. Okay. So when you have on and when we had a metal halide, it was almost 5600 K. And whenever you have a daylight, the color reproduction is the best.
Yes.
When you see the flower outside in the daylight, in the sunlight, it is the colors are the best. So what you should be asking is that how much Kelvin that light source is giving to you, whether it is a 75 watts, whether it is 125 watts. The important thing is to ask the manufacturer that what is the K value.
Correct. Right. So that is the reason we have to have the white balance to be done. When you have the light cable attached and the OT light should not be on, you should be doing it when the light cable is attached. The white balance purpose is for that purpose, to match the Kelvin to the natural Kelvin light. Yes, that's correct.
So three things are the most important as you mentioned. One, light cable. the light source, and your camera. And fourth thing, your arthroscope. These four things has to work in harmony to give you the best possible picture of the joint.
Yeah. Amol, you had a question.
Yeah.
Amol, you raised the hand. Yeah.
About the Indian manufacturers, like the camera and shaver, the costlier instruments, are they worth it buying?
I'll tell you, one has to go on the characteristics of this, not on the manufacturer. So if you have got a camera with minimum 500 lines resolution or a 600 line resolution, the manufacturer doesn't matter. Believe me, these companies, they are all buying their camera from one source. The basic camera comes from one source. It is the casing outside is different. Whether Stryker puts it, Stores puts it, Smith & Nephew puts it, they only have casing which is different, attachments which are different. That's all. The basic camera, which is the chip control device, CCD, and now CMOS, their cameras are not, they are not manufacturing it, they are sourcing it. Believe me, when in 1990 I started doing arthroscopy, I got a good camera which was used for surveillance in shops. I attached a C-mount monitor and started using it with the sheath. It was not a soakable camera. Believe me, so it does not matter so far as you know that it has got a good resolution. I used the surveillance camera which is used for preventing shoplifting. I'm talking of 1989. Okay, it was Panasonic camera. Okay, only the C-mount had to be got from the Stores company in Germany. But let me put it. So as far as the cutting instrument, I would not tell you to compromise on the quality of that cutting instrument. So you have to look at the cutting edges, the design of the instrument, the shape of the instrument. Is it having stress distribution? Is it having any projecting parts when you open up? If the Indian manufacturer has made it to the same thing, definitely go for local. But I have not used the cutting instrument. I would strongly tell you, use a local pituitary, a local probe, use a local grabber. Any of these instruments, even local curate you can use, rasp you can use. These are not very high precision instrument. Cutting instrument has to be very high precision.
Amol, the instrument that opens the joint inside the, the instrument that has a joint opens inside the joint, you should not use it, Indian manufacturer. There's a period. Because the hinges that opens up is the most important part of that instrument. And unfortunately, no Indian manufacturer is able to mimic that joint. So what happens that if you grab something, suddenly you hear a noise, tuck, and you know that the joint has come up. So please do not use any joint instrument with joint.
Basically, one has to go on the characteristic. Some of the Indian manufacturer might come out with it. Basically, the instrument I showed you, it moves like this. If you look at the instrument, there is no hinge pin. Hinge pin opens like this, but that instrument has a sliding mechanism.
Yes.
If you ever see the wings of the aircraft when it is landing, the flaps rotate like this. So it's the same mechanism inside this.
There are two questions. How often do you use mirrors inside the joint? Have you used it? Because you have been doing it traditionally. And
yes.
Have you ever had to use a magnet to retrieve a metal piece from the joint? So
yes, I'll tell you. Okay, mirrors we have utilized for once only in the beginning PCL to see the back of the knee. One can use a 70-degree scope, but believe me, if you are comfortable with the posterior medial portal, you don't really need the mirror. Okay?
Oh, Michael Strobel using the mirror to see the PCL footprint during the live surgery.
I have that mirror and I have never used this for last 10-15 years.
Yeah, okay. Nowadays we have understood that it
some places,
Yeah. So, okay. So in the beginning, I have a slide on I have a full lecture on complications of arthroscopy where it shows with the instrument which I broke inside. Once I was called by my colleague to retrieve something which he had broken. He could not retrieve it, so I had to go and redo it. So I took the magnet. The best way to get the magnet is from a speaker. Believe me, you will not be able to get magnets in the market easily. So the speakers which are used in the audio equipment, the large speakers, so that magnet we put in a sterile cloth and then covered it with plastic, and that is how we have utilized to retrieve. But believe me, that has been only once in the last 30 years.
Okay. No, there is a magnetic retriever available from Equifax.
Yes, I agree. But that, you know, when you are called into such a situation.
No. This is if somebody wants, because I have used it to retrieve the. There is a girl who was 12 years old who had a metallic part in the popliteal fossa. So you put this by the and it has a suction and it has a magnetic tip. So by sheer luck, I would not say it was by sheer luck the metallic piece came to in contact with this and I could remove it. So it's like used 3-4 times in the whole 25-26 years of the practice.
So you know, right, you're right. But you know, I was called by my colleague who had this problem. There are metal pellets, but believe me, those are not metallic. When you see pellets in the knee, you have had to remove them. Then they are basically lead pellets also. So they are not effectively removed by anything which is appearing metallic on the X-ray. May not be actually metal, it may be lead. So especially the
आपको तो इंडियन आर्थ्रोस्कोपी को इनाम देना है कि आपने इतना इकोनॉमिकल चीज बनाई है सब, and it is we are so grateful to you.
अरे नहीं, thank you.
You know, that means I'm amazed by your stinginess. I would say stinginess.
Not Gujarati. Gujarati saying it. If a Gujarati says it, it is a qualification. If a Gujarati says it, it is. Anyway, any more questions, please?
Sandeep has a question. Sandeep.
Yeah.
Sandeep, you are
Sandeep. It's regarding the same. Like question to Sir Bhasin sir and Nishit Shah sir also. Regarding that, how do we autoclave or sterilize this magnet in case we need to keep it handy in our set or something like that?
I just told you.
The reusable ones.
Sandeep, I will tell you what I am doing. The small fridge magnets that you have, the even smaller ones, I have EO'd few fridge magnets. They can be inserted via a grasper into the portal, through the portal. Especially right now our need is when your true pass or scorpion tip breaks. But luckily I have never used it, so I don't know on a practical way whether it works. But
no, I'll tell you, Bhupesh.
Ready, which I can hold with a grasper and put it in. I've kept it ready. Situation has not come, so theoretically.
Oh, no. What we have done is actually those are very weak magnets. The best magnet I told you is that sound system speaker magnet. So I got those magnets. I put them in a sterile, sheath, and then attached it to the back of the metallic grabber. So the whole thing becomes a magnet.
Yeah, and then you can,
Then you can. That's all. We don't put it inside the joint. We attached it to the. But believe me, if you can visualize it, if you can visualize the instrument, if the metallic piece, you will be able to find a way to reach it. You make another portal. Now we have become so proficient, we will be able to find a way. We really don't need to have this. But this was once off that I was called by my friend to help him out. That's the only time.
But Bhupesh, the netanol doesn't stick up.
I always have this,
or titanium.
Yes, practically I have never used. I don't know.
Because that's what when it is a because whatever those true passer
wires, our requirement now, I think the commonest scenario is breaking the tip. That is the commonest problem that we have. Sir, just to add to that wonderful slide you had shown on LED light cable, the light cable, which can get broken, and why we use a 5 instead of a 4. The practical implication is we have to teach our staff nurse, because anything like a rope long, they tend to use their elbow to wrap it up, if you know what I mean. And when they do a wrapping like that, they break a lot of metal pieces inside. So we have to teach them to put it in long circles.
Yeah.
Instead of
the fiber optic. Yeah. Basically, they are glass. That fiber optic is a glass, basically.
Yeah. And the second
works on the principle of
thing that you showed about the cover. We have now commercially available covers with a sticky in the front.
What is this? I don't understand. I didn't know that. What is this you're saying?
Instead of putting the wire and twisting it and using a steri drape cut, commercially available camera covers with a sticky in them. And for reinforcement, what I use is from your sticky drape, I cut one corner of that sticky drape, 10 millimeter into say 10 centimeter long cylinder I cut from your sticky drape and reinforce it. The camera cover itself comes with a sticky. For reinforcing, I use the.
So I was making the, Bhupesh, I understand. I was making the inside sticky by twisting a string, and then we also put the outside sticky. What I was just talking to you, I was thinking, have you ever seen, you know, those plastic locks which comes when you are traveling abroad? They put it instead of your lock, they put that plastic ratchet lock.
Correct. Correct.
I have not used it, but the idea came to me while you are talking. If a plastic ratchet lock can be ethylene oxide, then it will work very quickly. You just tighten it. I'll try it.
Sticky ones are very secure, sir.
It can be autoclaved.
Are coming now.
No, plastic. That is plastic, which these airline people put when you want to lock the luggage. It goes in and then it locks very hard. When you reach your destination, you have to have a scissor to cut it. Okay, so I will try it next time and I will put it in my lecture. Idea just came while talking.
Bhupesh, the thing.
Yes, sir. Dikha raha Sandeep. Yes, Sandeep.
So, yeah. Good.
Sir,
Have you used it?
Sir, it can be autoclaved.
Okay.
Yes, it can be autoclaved.
Same. Yeah. Wonderful.
We autoclave it.
So CME, good. Combined medical education.
Yes.
We learn from each other.
Yes, that's right. This is wonderful. Even the thought came to me right now, and he's already using it.
Yeah.
So this is wonderful.
In any shop also, any cycling shop.
Yes.
Yes.
Yeah. Well, anywhere, sir.
So my one question would be, so the newcomers, of course, for who are watching this, now all the instruments, what we're talking of, which don't have an hinge side, now they're not made in India. They're very, very expensive. A good punch or a good grasper comes not less than 50,000 rupees by all these big companies that make them.
Correct.
Now, after so many years since say you started, don't we have any Indian option right now?
I would not compromise. You know, it used to, in 1986, it used to cost exactly $600 to $700. $700 in America, if you buy, if you could get directly, you could get a discount up till the list price used to be $700. Even today, it is $700, except that the dollar has become 74. That time, dollar was 12 rupees. Okay, but Indian manufacturers, I don't think the price in America is still $700, which I originally bought at that time. So it is still the same, but if Indian manufacturers have to come up, I don't know. If Chinese have come up or not, I don't know.
Dr. Nishit and Dr. IPS, any idea on this?
See, you cannot compromise with when you are using with the patient, you know, and उस टाइम हम 12 रुपये जितना कमाते थे तो अभी हम वही इंस्ट्रूमेंट अभी 74 के मेन्यू
Yes, sir. Please continue.
Yes, sir. Dr. Nishit, yes.
Continue, sir. Your voice. I think this internet is weak, I believe.
Nishit, sir, please continue.
Bolo.
I think his internet is a problem.
So I think Sameer we must invest.
I think poor connection.
I think there is a problem with the internet. Anyway, sir, so any questions, Tirath, any Amol? So
yes, sir. I do have a question.
Yeah.
It is in continuation with Sameer sir's question only. Sir, commercially, there are many different type of punches which are available with different specifications. So in order to start basic knee arthroscopy and procedures like meniscectomy, what bare minimum punches that you would advise we should buy as a beginner?
15-degree up punch, 1.5 millimeter wide. Believe me, I am still using the same watch I used 20 years ago, 30 years. Some of them are lasting 30 years because the way they have been cared for. So it is important. What Sameer is saying is very relevant. Cost is important, but then you must take care of the punches yourself. in those videos, I was washing the punch and the scope myself. Okay.
Yes.
So it is important to have one instrument, but good quality. If you have to have a second, then buy a rotary 90 degree. Again, I have not seen Indian. It should be rotary 90 degree. There are ones which are available as grabbers 90 degree. Don't buy them. They don't work. They are cheaper, but rotary 90 degree and up punch, 2 punches you must have.
Tirath, basket punch, what sir says, Dr. Bhasin, basket punch is good enough. You can do all meniscus things with that. And Dr. Bhupesh, regarding your comment on the breaking of the fiber optic cable, I think these two things, I do it personally every time. I don't depend on any staff. It's my investment, or the hospital's investment, and I have to do my surgeries. So I don't depend on anybody. This is the only thing I do. I take care of the instruments, and it takes just 5 minutes.
I think that is the single most important take home today, what Bhasin sir said and what you're re-emphasizing. We have to wash our instruments for it to be safe. I think that is the most important thing today.
Absolutely.
And about the
Absolutely.
being sterilized, there's something I would like to share, which I've been doing for the last 2-3 years. Now, all the arthroscopes come with a packing. It has got a foam which is cut in the shape of the arthroscope itself. So what I do now is, I take this cardboard box, take your 4.5 drill bit, and make multiple holes like you see in any other autoclaving box, and then keep the foam back inside. After using your arthroscope, wash it with water, dry it by yourself, put in all the plastic caps on all the sides, put it back into the same cardboard box now, which is perforated with the original foam cover, and you can safely send it for plasma or EVO. Because it is inside the foam, it will not shake, it will not break, and this packing is very sturdy, and ethylene oxide more safely plasma will penetrate this and will autoclave. It is safer than Sidex or your formalin. So
very good.
Bhupesh, how often you have to change this?
Change what, sir?
This box?
Sir, I right now have 2 scopes with me. Both these scopes, I am using only the manufacturer's box till today.
I understand.
The cardboard box.
Not to change that all, sir. You remove it, use it, put it back into the same box.
To keep the sponge, right?
Yeah,
Yes,
the sponge, same sponge I use.
Does the gas penetrate the sponge?
Yes, sir, it does penetrate. I have tried this with biological markers also. It penetrates inside.
Okay, and okay. So it's a good. I mean, the original box, it will be very, very nice, you know.
Absolutely.
So you bought the sponge both the side or only one side?
No, sir. The original box, original sponge will be the same. I only remove the sponge, keep the empty box, make multiple drill holes on all surfaces, and then put the sponge back with the arthroscope and send it for EO.
Right.
Yes, Sandeep. Yes, Sandeep.
Sandeep, unmute.
Yes.
Sandeep,
So one is like, I would like to show Tirth. This is that rotary 90 degrees rotary.
Yeah.
I think Sandeep is sitting in the operation theater itself.
He has an operation theater in the house.
He from his magic box.
That's the thing. I use it for autoclaving like as it is. I just give it for autoclave.
No, that's correct. That rotary punch is a very good punch.
Yes,
that rotary punch which you showed is a wonder. This is the only one which is working in the world I've seen.
Absolutely.
And this one is the scope. Like I got it from US when I was coming back. So it's a very good container where you can put your scope.
Absolutely.
Yeah.
It's very safe.
Yeah.
Like the Bhupesh was mentioning.
The rotary punch is now relevant, you know, because now you become very good in putting the portals. So you can put an extra portal to come on the anterior side or the anteromedial side.
Correct.
And then start
because rotary punch, what happens that it needs a lot of maintenance. Because otherwise, you know, it gets jammed after sometimes.
Yeah.
So I think that rotary punch, you should be invested when you have a lot of money, and when you want to have then you invest into rotary punch. Otherwise, rotary punch at this moment, and inside for that this is a rotary punch. You have also the simple same scissor punch with a 90 degree, and that
it doesn't work. It doesn't work. I don't know.
like rotary works very good.
Yeah, rotary.
So I think, sir, we have learned a lot from each one of participants, including
Yeah.
those who have actually logged in. And I think that is the beauty of these kind of webinars. You carry home at least 2-3 good points, and you become wiser. Even in the basic stuff, we have become wiser very much today. And I think younger people would have become wiser than all.
Thank you. Thank you.
Thank you very much, sir, for joining in. Your talk regarding triangulation, we would love to see it maybe next
See
time.
you other time. Yeah.
Because
Okay.
it's always better to go step by step and then have a lot of
Right. We'll do it some other time.
Yeah, so we'll do other time. Thank you
Thank
very
you.
much, Bhupesh and Sameer, for helping us out in this webinar. Thank you, Tirath, Amol, and all
Okay,
our friends for joining in. Thank you, Bhasin, sir, as always.
Thank you. Thank you.
Friends, next.
Thank you, sir. Thank you for giving this opportunity to be here.
Thank you. We have our 50th webinar, and this is a interesting webinar because we have from Stedman Clinic, Dr. Peter Millett himself joining in, and he's going to talk about shoulder arthroscopy and essentially into rotator cuff tears. Where are we today? Let's hear Peter Millett on 19th of June at 7 p.m. and we celebrate our 50th webinar at that time. Thank you very much for tuning in. See you all
Beautiful.
in June now. Thank you.
Thank you.